In this video, we will review the Indian Hip Surveillance Guidelines for children with cerebral palsy. This video is intended to help health professionals apply these guidelines to maintain optimal hip health in children with CP across India. Of all children with CP, more than 1/3 will develop significant hip displacement as they grow. With early detection of hip displacement, treatment can be initiated to keep the hips in joint, helping to preserve function, prevent pain, and potentially prevent other deformities. To facilitate early detection, CP hip surveillance guidelines were created, then customized for use in India via a multidisciplinary collaborative project supported by the I'm a Hippie Foundation. Any health professional who is working with children who have cerebral palsy should be aware of the guidelines and should ensure that each child with CP is having their hips monitored by a designated physician or therapist in their community who is familiar with the guidelines. All children with cerebral palsy, regardless of whether they can walk, should be having their hips monitored. However, functional level correlates with the risk of hip problems developing in these children. In CP, functional level is described using the Gross Motor Function Classification System, or GMFCS for short. Determining the GMFCS level is key to determining how often and how the hips need to be assessed. The GMFCS 1 and 2 levels include children who can walk without walking aids. Both of these levels are associated with a low risk of hip problems. The one exception to this is the child with hemiplegia who walks with a winter gauge Hicks type 4 gait pattern, where the affected hip is excessively flexed, adducted, and internally rotated. This type of gait is associated with a higher risk of hip displacement. Children who require assistance to walk or who cannot walk at all have progressively higher risks of hip displacement and need more frequent monitoring as a result. For a more detailed review of the Gross Motor Function Classification System and its importance in CP, please refer to our module on hip assessment in children with cerebral palsy, available on the website of the Hip Hope Network. Hip monitoring in children with CP should be carried out throughout childhood, with frequency depending on GMFCS level. Monitoring involves both clinical examination and X-rays. For level 1 or 2, the hip should be examined every 2 years until age 10, with X-rays obtained every 4 years during that period. If they're doing well, ongoing monitoring of the hips is only required after age 10 if they have a winter gauge Hicks type 4 gait pattern, in which case monitoring is continued every 2 years until hip growth is complete. For level 3, clinical and X-ray examination of the hip should be conducted yearly until age 8. And then every 2 years until growth is complete. Finally, in level 4 or 5, clinical and radiographic examination of the hip should be conducted every 6 months until age 4, and then yearly until skeletal maturity. This summary table of the schedule can be found on the website of the Pediatric Orthopedic Society of India. Clinical examination as per the CP hip surveillance guidelines consists of confirming the GMFCS level and gait pattern so that you can ensure they are monitored frequently enough, assessing maximal passive hip abduction to detect the hip at risk for migration, and assessing for pelvic obliquity and scoliosis, as these factors can result from or result in progressive hip displacement. X-ray examination consists of an AP pelvis plane radiograph with the patient appropriately positioned, using modifications as needed to accommodate for any fixed hip flexion contractures. On the radiograph, migration percentage is measured to quantify how much of the femoral head is left uncovered by the acetabulum. Step-by-step instructions for measuring migration percentage can be found in our module on radiographic assessment of the hips in cerebral palsy, available on the website of the Hip Hope Network. When both hips have a migration percentage less than 30 and the patient is otherwise doing well, continue to monitor as per hip surveillance guidelines. When either hip has a migration percentage greater than or equal to 30, or the migration percentage is less than 30 but hip abduction is less than 30 degrees, or the child has pain on either clinical examination or during activities, a referral should be made to a pediatric orthopedic surgeon for assessment and discussion of potential management options. If the migration percentage is less than 30 degrees and there is no progressive pelvic obliquity or scoliosis, and the patient reaches skeletal maturity as seen by closure of the triradiate cartilage, hip surveillance can be discontinued. Using the Indian CP hip surveillance guidelines, we can help ensure children across India with cerebral palsy are able to function comfortably at their maximum potential. Further educational materials on this and related subjects can be found on the Hip Hope Network's website. Please note that the material presented in this video is strictly for educational purposes and is not intended as medical advice to patients or their families and should not be used as a substitute to proper medical assessment. Thank you.